Okay, we're starting in a few minutes.
Hi, John.
Hey, Sharaf, how you doing?
I'm good, John. Can you give me 1 minute, John?
Yeah, yeah.
Give me 1 minute. Huh? Right.
Take a few minutes because I'm going to promote some more. Okay.
Okay. Thank you. Sure.
We're starting in a few minutes. Okay. Well, I just got some great news.
What's that?
Guess who approached me to help televise a conference?
I didn't get it. Sorry. I didn't hear you properly.
Guess what institution came to me and asked help in televising?
Oh, no idea.
Harvard.
Oh, great.
Yeah, I mean, that's a top name.
Great.
Yeah, that's a big break. Because the name. Hello, Nargiza.
Hello.
Hi, Nargis.
Hello,
How are
Dr.
you?
Surat. Thank you.
Yeah.
I'm fine.
Long time no see.
Yes, John sir, I just have to tell that already known Dr. Surat. We met in May in Sri Lanka, and I had a great opportunity to assist and to work with Dr. Surat. So I was very happy to join for this webinar today.
Oh, good. Where are you at? Where are you at now?
Right now I'm in Istanbul, but I was in Sri Lanka in May, and we met with Dr. Surat during the whole week, I guess. Yes, I was attending and coming to the Ratnapura hospital. So it was great.
You're welcome. He's pretty regular on this channel. So
thank you.
You'll see him pretty often.
Yes.
Yeah, so we had a good time there. So Nargisa wanted to see how we perform the cases at the one of the most peripheral centers in Sri Lanka. So I think she had a good 3-4 days of good interesting cases. Yeah,
good exposure.
Yes.
Yeah, are you a student, Nargisa, or resident?
I already have done with my residency in Russia. So now I'm doing my fellowship. So I was 3 years with Professor Raip, and right now I'm in Istanbul doing my pediatric neurosurgery and trying to travel around the world, attend conferences, webinars, and join some doctors for the short period during my vacation.
well, you know, I didn't realize it before getting involved with the neurosurgeons, but neurosurgeons tend to travel during residency, which is great. They can go, I don't know, Sarath, you went places for a month, 2 months, like fellowships and stuff. Did you do that? Did you travel?
The thing is that the program, neurosurgical program in Russia, where I have done my residency, is just 2 years, unfortunately. So this is the program. And after 2 years, I realized that I have a lack of knowledge and I want to continue. I want to learn and to have more opportunity to meet big doctors. So I started traveling. So my travel started in India.
It's a great opportunity. We do a lot of webcasts with IPE. I was in Nepal with IPE for 3 months. So I got to meet a lot of neurosurgeons and, you know, this is a great way to meet neurosurgeons like Dr. Sarath. I mean, to meet them is golden because, you know, for the rest of your career, you're going to be interacting with the community. It's not a huge community, as you'll see eventually. We've done some Russian webcasts from Manuel Encarnacion. He's a resident in Moscow.
Yes.
He does, and you're always welcome to either do a webcast or just join. You can join any of them, like you did for this one. So, okay, Sarath, you want to start?
Yeah, I'm ready, John. Let me know when you're okay.
Okay, let me just get the. I'm always ill prepared when I start, and I don't know the titles. Hold on.
Sure.
Okay, here we go. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV based here in Miami Beach. And the internet's wonderful. Go all over the place, including Sri Lanka. We're doing a Sri Lanka neurosurgery grand rounds. We've done a lot of them with Sarath. And matter of fact, the link is in the link to come into the webcast. So you can see years of webcasts we've done with Sarath. And Sarath is going to speak today about quality of care versus availability of resources in neurosurgery, because most of the world, 5/6 of the world, doesn't have a lot of fancy equipment. They have to work with what they have. And Sarath brings us to that side. So welcome, Sarath.
Thank you, John. Thank you very much for the opportunity, because I think you're doing a great job to the neurosurgical fraternity, because you have been doing excellent over the last few years, giving us opportunity, especially like people like us in the developing countries. So it gives some light to the rest of the world of some kind of an idea of how people like us in developing countries and peripheries with poor resources are doing. As you know, you see most of the webcast done by the affluent societies with all these equipments and the instruments. So you see a lot of hi-fi stuff, the high tech, but I think, as you said, majority of the neurosurgeons in this world, they don't have that type of the resources, the facilities, and the opportunities. But it doesn't mean that poor resources means poor qualities. It doesn't. It is not equal, and it's not directly proportional in that manner. So whatever the resources available, whatever you are having, so we are trying to provide the maximum, considering the patient's safety as the first priority. So that's what I have been talking over the last few years, because I have been working in the most difficult part of my country, teaching hospital Batiklo and teaching hospital Ratnapur Ratnapura is the most the hospital I'm working now is teaching hospital Ratnapura. Is the most underdeveloped and most recently established neurosurgical center. So so resources wise, it is the one with the poorest resources. So what I have been trying to tell the world is how to get the maximum benefit of the resources available. So today from neurosurgical grand rounds, I'm going to show you what we have done for the last 3.5 years and what we have achieved with innovations considering the patient safety. And if I can give the rest of the world and a message on how to perform surgeries under difficult circumstances, I think I have achieved my goal. So thank you, John. So let's start the presentation. So I'm going to share my screen. I hope you can see it.
Yeah, yes, full screen.
Right. Yeah, sure. Okay.
Yes, perfect.
Right. So, so when we talk about neurosurgery, so we commonly talk about innovation in neurosurgery nowadays. So innovation is a key driver for improved patient outcomes, as we know. So the ultimate goal of innovation should be to improve the patient quality. And for people like us, at the same time, we need to reduce the cost. So it has to be a cost-effective innovation, which is going to be very helpful for peripheral neurosurgeons and neurosurgeons in developing countries. So before that, to introduce myself, as I told you, I'm a neurosurgeon who has been working in under the most poor resources for the last 5 years. So I have tried innovation, thinking about the patient's safety and the patient improved outcomes. So that has to be the goal for any kind of an innovation. So the new treatments, new technologies and techniques. So need to identify the possible opportunities for improved outcomes. And at the same time, when we talk about neurosurgical practice, we need to talk about errors in neurosurgery, because patient safety and errors go hand in hand. So we always try to give the priority to the patient safety, minimizing the errors, minimizing the human errors and the technical errors. For us, we don't have much technical support, so we mainly depend on the basic, the surgical techniques, whatever it is, microsurgical. Most of the time, it's microsurgical. So as we all know, it's a neurosurgery is a high risk specialty with a high level of complexity. So medical errors are common and they are dangerous in neurosurgery, especially because if an error happens, I think it's going to affect the patient's outcome very, very badly. And depending on the literature, we know this is the percentage of all the errors in neurosurgical cases, and 25% roughly are related to the surgical technique. So the most errors occur within the context of complete healthcare system. Like it's not just the surgeon, it's the nurses, the technicians, the administrators, and the patients themselves. So the errors, just to talk a few things about the errors have been defined in various ways. And this is the definition. I'm not going to detail. So this has been elaborated in the literature by Stone and Bernstein. And we need to understand that the economic burden of a surgical error, especially in neurosurgery, is great, because I can show you examples, a lot of examples which happened to me, and that has a direct relationship with the available resources and also human errors as well. So neurosurgical patients are handled by the complete healthcare system. So that is very, very evident when you are working in difficult circumstances. So it is not just directly related to the surgical technique. So a few factors regarding the adverse effects. So adverse effect events are another aspect. So these are unexpected perioperative complications. as well as anticipated neurological deterioration related surgical approach. So these are a few points I have included a few points here. So we need to avoid or mitigate these adverse events always if you want to improve the quality of care and to improve the outcome. I am specially talking about this because when you are working under difficult circumstances with poor resources, you have to think always about the safety of the patient and the patient's outcome, and also the errors or the difficulties you encounter. Because if something goes wrong, and when something goes wrong, you should be able to justify your work, justify your decision, and it's going to be really tough and really difficult when things starts going wrong for you under difficult circumstances, because it can further put you into deep trouble. So how to reduce errors? So this is another important thing that we need to keep in mind. So reducing the errors, I think it's better to talk about this with some examples as well. So I will talk about this later. So we'll go to the cases, and we'll discuss about this at the same time. So let's talk about innovation for improved outcome and cost effectiveness in my center. So there are a few things, a few techniques that I have learned, and I have practiced, and I have experienced over the last 2-3 years. So one is this evacuation of hypertensive intracerebral hemorrhages through mini craniotomy. So this is what we have done, what we have achieved. We have done 324 cases of ICH evacuations altogether for the last 3.5 years at Teaching Hospital Ratnapura, which includes and arteriovenous malformations, aneurysms, amyloidosis, and hypertensive, including hypertensive ICH. And out of that, we had 270 cases of hypertensive ICH over the last 3.5 to 4 years. So the main reason we did, we actually, I'm continue. It's a continuous study. So this study is being carried out for the last 4 years, so it's still ongoing, and it's a single surgeon experience with a retrospective analysis from 2019 to 22. So as a single surgeon, I have done this at Teaching Hospital Batiklo and Teaching Hospital Ratnapura. The special thing about it is, even though there is a neurosurgical unit, we did not have a separate neurosurgical ward in both the hospitals. So this study, we included 99 males and 45 females. So what we did, so this is what we did. I think I have presented this several, 2 or 3 times before. So this is what we did. So we see lots of patients with hypertensive ICH every day in my hospital, because most of the patients in my area, they think hypertensive is a curable disease. So they take sometimes they don't take medication because they go for the other native treatment or Ayurvedic treatment. But most of the times what they feel is they take medicine for some time, and then they default thinking that their hypertension, their disease is cured. So they present with all these hypertensive intracerebral hemorrhages. So what's the problem? So as I mentioned, we don't have HDU facilities, ICU facilities. So we don't have space to accommodate all these patients. So these patients are being admitted to the medical wards. So at the medical wards, I can tell you, without any doubt, they're being mismanaged. That's very common. It's not the fault of the medical people, but they have lots of patients, and they, most of the time, for example, when we say conservative management, the true understanding of the conservative management is not being conveyed. And that's why I use the word they are being mismanaged. Their blood pressure is being not controlled properly. And most of the time what happens is they get aspirated because of the reduced level of consciousness. They present with aspiration pneumonia, and the mortality was very, very high. The mortality is very, very high. So this is the most common cause for death of this patient is aspiration pneumonia. So this is what I witnessed in first few months, and then I realized that we need to do something for that. We just can't let them in this state. So what I did, I selected patients with low GCS presenting with a GCS of less than 9 initially, because we cannot we don't have times and space. We don't have space in the theaters to evacuate all this. So I did evacuation of these intracerebral hematomas, mainly with the purpose of saving their lives. So we have problems like lack of anesthesia, lack of anesthetic team, and lack of ICUs. So what we did these cases under local anesthesia or sedation. If the anesthesia is available, we did them under general anesthesia. So I did it through a very small incision because it takes less time, probably less than 60 minutes. And we evacuated these hematomas, and most of the time we did not have ICU beds post-operatively. So most of the patient, a high percentage of patients underwent tracheostomy at the same time, or tracheostomy, even though they were sent to the ICUs prematurely. Again, prematurely, we had to mobilize them to the wards with the tracheostomy because of unavailability of the ICU. So these are few cases of such evacuations that I have done. So I can show you hundreds. So this is the incision that we put. It's a very small incision. Usually I go through the middle temporal gyrus. I used to go through the middle temporal gyrus, either transsulcal or transgyral most of the times. And sometimes we put an EVD, because when the patient deteriorates, when the GCS drops, I insert an EVD. But if you insert an EVD, so you have to operate as early as possible. So this is what we did. We don't have navigation, so we just use these craniometric points, and this is what we achieve. So around 80% to 90% of the hematoma is evacuated most of the time. But sometimes if it's under local anesthesia, it's difficult to achieve the complete evacuation. But I don't think you did not. I don't think that you need to completely evacuate, because at least 75 to 80% of evacuation is enough, because the effect of these blood products and the hemoglobin degradation products that causes this toxicity to the brain can be relieved and reduced by evacuation of this. So you can see again large hematomas being evacuated through a very small hole. You can achieve it. It's not easy, but once you practice it, I think it's not a difficult task. So again, this one was done under local anesthesia. So obviously we couldn't completely evacuate, just around 70 to 75% of it. So you can see the patient had a tracheostomy and left-sided weakness. Again, another case. So this patient improved very well. You can see it's the right-sided hematoma. So we have understood that right-sided hematoma generally show a good outcome compared to the left side. But in my scenario, I had more left-sided hematomas than the right-sided hematoma. So she is the oldest lady I have evacuated. I had operated. So far, she's 75. It's a large one, but she did very well. So again, another one. Now I have, now you can see the difference here. Now I have used a frontal burr hole. It's like you are putting, it's like you are putting an EVD through the arches. So it's similar to the endoscopic evacuation if you do it without manipulating the surrounding normal brain parenchyma. So you can see how small the mini craniodome. It's like a burr hole. I will show you the video of this. So this is the next day. So around 90% of the hematoma is evacuated. So this is the lady. So this is recently done. So she's a patient with actually a pericarditis. We didn't know that. So we came to know after doing the 2D echo. And so this is the most difficult part to manage aspiration. You can see she was tracheostomized, and one of the nurses trying to give her some water so she can swallow. So she was recently discharged. So this again, another case, you can see it's through the frontal burr hole, very small frontal burr hole. I have achieved around 90% evacuation. So you can do that as well. So it doesn't need to be a temporal burr hole. But the only thing, if you go through the frontal burr hole, you need to have long instruments. So that is one of the there are limitations to me because I don't have long bipolars. So this is this patient. So you can see, can you see what has happened? This is his chest X-ray. You can see the haziness here. So this is what happened. So his GCS was initially 13. So we did not want to operate him. Then he presented with this. And you can see this is the, at the time we brought him to the theater, you can see the breathing. So at the same time, we did tracheostomy, and this is the incision, a small incision. Right. So this is another case of ICH evacuated through the frontal burr hole. You can see, I'll show you the so that's the preoperative the CT. This is the immediate post-op CT. The next day after evacuation. So again, it was evacuated through the frontal burr hole. Right. So this was on 24th of. So this patient presented to us on 22nd. So we inserted an EVD on 23rd, and we operated on 24th because he did not improve, because he further deteriorated. And you can see this is on 26th. So see the CT. You can see it's fast resolving. So that is the so you can see the bone flap is being kept floating. So it's a very small bone flap, but I always try to keep it floating. So you can see it's a very small bone flap there. So this is that patient. So you can see the patient underwent a tracheostomy, but we have saved their lives. They get the disability, we send them to rehabilitation, but we have prevented them from dying. That's what we have achieved for the last the few years. So not only ICH, even the IVH as well, the intraventricular hematomas. So I have evacuated intraventricular hematomas through the parietal burr hole as we are doing an EVD. So let me show you a few videos on that. So one thing I realized that when you go through a temporal burr hole, sometimes it's difficult to achieve a complete evacuation because you make a small hole and you you use your bipolar or whatever the instrument as the fulcrum. And so when you use a small burr hole, it's difficult for you to manipulate or move in a distance, in a bigger distance. So therefore it's difficult for you to achieve a complete evacuation. But if you go from above, like we're doing the endoscopic evacuation, if you have adequate length bipolars and the instruments, I think you can achieve a better, you can cover a better area, and you can achieve a good amount of hematoma evacuation. So this is evacuation through the frontal burr hole. So sorry about the quality of the picture. So this, you can see it's a very small opening, and so you make the cortical window and you directly go through the cortex deep into the hematoma. So you have to be, sometimes I use the retractors, but most of the time I don't like to use these retractors. Sorry about the quality of this video. So you go directly and you don't want to make the hole bigger laterally, because you want to minimize the manipulation of the normal brain parenchyma. So it has to be like a cone with the angle downwards rather than going laterally. So I use the sucker as the retractor, and the bipolar. So, and sometimes I use the ranches. So you take out the whole the clot, so without damaging the rest of the brain parenchyma. Unfortunately, I did not have time to edit this video, so this is the whole video I'm showing you. So sorry about that. So it takes around 40 minutes, 30 to 40 minutes to completely evacuate the hematoma. And you take around 10 to, so you have done the hematoma evacuation, so it's only 27 minutes. And then you achieve the hemostasis. So we don't have like TISIL or FLACIL very frequently and leisurely. So we only have Surgicil, so we need to give a considerable amount of time for achieving hemostasis. So that's the most important part, at least 10 minutes for hemostasis. So I'll show you another one. So I think I am having the full video here. Let's see. Yeah. Right, so this is again through a frontal burr hole. So unfortunately, our drills are defective, so you can see. Sorry?
It's better quality video. It was.
Yeah. This is actually the defective, what you call this, the drill. So the drill doesn't stop at the dura and it penetrates the dura. It happened to us quite several times. So this is what happened. So again, so this is you go straight to the clot, and you without manipulating the surrounding normal brain parenchyma, you evacuate the clot very, very gently with the sucker at the very slow pressures, and let the clot come towards you rather than chasing the clot. So otherwise, there is no point in operating in this way through a small burr hole. Your aim is to minimize the damage, the collateral damage to the adjacent brain parenchyma, and get the clot as gently as possible. So I had to use the retractor most of the times when I go through the frontal burr hole. And I think I have shown cases of evacuation through the temporal burr hole. So I'm just showing you through the frontal burr holes only. So you can see 22 minutes. So roughly it takes around half an hour to achieve the hemostasis. So the total procedure takes around maximum 1 hour. Let's show you another case. So this is the one with the pericarditis. I showed you the lady. This was done last month. No, it's this one. Yeah. Right. So this is the burr hole you make. You make a small corticotomy and you go straight down. So you have to be very clear and very thorough with your craniometric points, and otherwise, if your marking is incorrect, so you are in trouble. So you can see it's like a cone. So I don't want to go laterally and damage the normal brain parenchyma. So take the clot out, put a lot of saline. That's very important. It softens the clot. And let the hematoma come towards you rather than chasing you. That's the last bit. Minimal bipolar of the adjacent brain parenchyma. You can see I have used the retractors in all these 3 cases of going through the frontal burr hole. So that's it. And you achieve hemostasis. So that's about the frontal burr hole evacuation. So let's show you a case of IVH evacuation as well, as I showed you the CTs before. This is an IVH with thalamic ICH. So this is what I do regularly. So again, a small hole. You make a corticotomy. So at the same point as you are inserting a VP shunt, so you go directly, and now you are getting to the hematoma. So now you are within the hematoma. It would have been much better if I had edited these videos. So I will try my best to edit these videos because I have no time working as the 24/7.
Editing is time consuming.
Yes, it's very much time consuming. So I work my skin out 24/7, and Friday is the only day I actually have dedicated to my research work, and that is the only day I go through all these cases and I call the patients and I go through the patient details. So that's how I do this research. And Saturday, Sunday also same. So most of the time the personal life is also being sacrificed. So it's very extremely difficult when you are working under these circumstances. So it's very difficult to find out time to do these editings. Okay, so that's all about this ICH evacuation. So this is the post-op CT of that. This is one. This is another case. So this is the case I showed you. You can see it was a large hematoma. Unfortunately, I don't have the pre-op CT of this patient. I couldn't find out. So I have evacuated it and I have put the EVD towards the same burr hole. So that was one innovation that we did. So we have achieved good outcomes. So this is the study, and this is the result we achieved. So study included 99 males and 45 females. The average operative time was 42 minutes, and the average volume of ICH evacuated was 34.5 milliliters. So 94, as I mentioned you, 94 cases, 65% were left-sided hematomas in my study, and for 50 only right-sided. So we had done 68 tracheostomies in these patients. So you can see nearly half of the patients underwent tracheostomy, but we saved their lives. So tracheostomy at the time of evacuation, 40. That is mainly due to the lack of post-op ICU beds. So you can imagine it's the only hospital to the entire province draining more than 15 peripheral hospitals with a population of 3 million people. It's the only hospital which has only 17 ICU beds. For the 70 consultants, 70 specialists, there are 70 specialists, only 17 ICU beds. So obviously you can see neurosurgery is just a specialty, a subspecialty, if you consider the entire hospital. So they definitely, they are not giving you more than 2 ICU beds per day. So that is reasonable. Actually, it's justifiable. So we can't ask more. Sometimes we have 4 or 5 patients in the entire ICUs. So this is what happens most of the time. So this is, I'm sure this is, it's a big problem for most of the neurosurgeons who are working in developing countries. So it's not it's not an issue only for us. So most of the time, even in the affluent countries, European countries, when I was working in UK, the best centers, even those centers, we had, I mean, difficulties in obtaining an ICU bed. So there is no point in talking about developing countries, peripheries like us. So only 79 out of 144 patients were sent to the ICUs due to the shortage of ICU facility, and 65 patients directly sent to the ward. So ward means it's not a complete, I mean, it's not a complete setup with facilities. So it's just the corner of the orthopedic ward with 6 beds for the male patients and 4 beds for the female patients. But we have achieved, and we have done that much amount of, we have operated that much amount of cases, we have managed that much amount of cases and patients, and we have saved patients' lives. So that's, I think, a big achievement. So you can see, as I showed you, most of the patients were having left-sided ICH involving the verbal component. So when we assess the GCS, most of the times they are localizing, but their GCS is low because the verbal component is not there. So we had around 30-40 patients like that. So those patients, actually, we send them directly to the ward rather than sending to the ICUs. So these were the results. So 30-day mortality was around 12.5, and mortality at 6 months was 16%. I think it's I mean, it's a very good good figures when we consider the percentages in the literature. So this is the average length of ICU. It was just 3.45 days. That's actually not a true reflection of the true values, because most of the patients, they were prematurely sent to the wards, mobilized to the wards with the tracheostomies. So average length of hospital stay was around 8.5 days. Only rebleeding occurs in 5 cases, 2 died, 2 managed, 1 conservatively managed, and 2 re-evacuated. So number of patients developed pneumonia. You can see it's a high percentage. 30% developed pneumonia during the hospital stay, either hospital-acquired pneumonia or aspiration pneumonia. Aspiration pneumonia was the most predominant one, and number of patients died of pneumonia over a period of 6 months, 10. That's because we had a higher percentage, higher rate of tracheostomy, early tracheostomy, I think, which reduced the number of mortalities and morbidity due to pneumonia. Right. So that is one innovation we have experienced. So let's go into the next one. So the next one is the short same segment fixation for the unstable thoracolumbar fractures. So we get lots of thoracolumbar fractures in my area because it is occupation related hazard, because you can, because I don't know whether you you are aware, because Ratnapura is the main province which is famous for gems in Sri Lanka. So there are a lot of gem mines. So these people, most of them are gem miners working in the mines. So they climb up and they fall, and also they climb trees very frequently because they need these what we call this the woods and the things which are needed for the mines. So they usually climb trees and then they fall. So lots of fall from heights causing thoracolumbar fractures I have witnessed over the last 3-4 years. So overall thoracolumbar fixations over the last 4 years, it's 144. So out of that same segment fixation, I have operated 98 cases, and out of that, and out of this 144, there were 33 thoracolumbar fracture dislocations, which is quite a high number when you consider the frequency of these dislocations. So we had a good short and long-term neurological outcomes with the same segment fixation at a 1-year follow-up with regard to the hospital stays, the VAS scores, the ODI scores, and the low failure rates. And the most the important or the main reason I opted this short same segment fixation, because it's cost effective. Because you can see the main problem for us is the screws, the resources. We don't have these pedicle screws provided by the government for the last 3 years. Very recently, only 1.5 months back, we received them from the government. So so all these patients who come to us have to buy from they have to afford a private construct. So most of the time what happens is they cannot afford, because one pedicle screw is around 33,000 rupees, 33,000 Sri Lankan rupees. That's I mean that's also either a Chinese one or an Indian one. If you go for a German one, it costs around 70,000 Sri Lankan rupees. So the monthly income of these people are usually around 50,000 rupees. So you can see if we need 5 screws at least, so it costs around 150,000, more than 150,000. So which is 3 months income for a poor patient. So it's not affordable. You can see it's not affordable at all. So how do we perform these cases? So what they do is they usually take loans. So they find this money by various ways. Right. So it's being really pathetic, actually, to hear their stories. But they want to get the surgery done because they have seen the outcomes and they have heard from the other patients before. So I think it's a very good achievement for us. So we have done, I mean, quite a lot of cases, and we have achieved a good outcome. So even though they are at risk financially, they have kept faith on us, and they have achieved, or they have received what they wish. So there are lots of cases. So sometimes, if they could afford, we have inserted we have inserted pedicle screws at both the pedicles at the fracture site. But sometimes, if they cannot afford, or if the pedicle is blown up, pedicle is disrupted, we go for just one screw at we insert one pedicle screw at the fracture site. So you can see all these cases. We have inserted, we have fixed both the pedicles, and yeah, so CTs, and most of the times we are not being able to get the MRIs done because it's difficult to get an MRI done as early as possible. So these are single pedicle screws inserted at the fracture site. Either they couldn't afford 6 screws, so either the pedicle is broken. So I have conducted a study on this as well. So what I have realized is there was not much difference whether one pedicle screw is inserted or both the pedicle screws inserted at the fractured level with regard to the neurological outcomes and the pain scores and the ODI scores. But the only thing is regarding the kyphosis correction, when you insert two pedicle screws at the side, the immediate post-op kyphotic correction is better. But as the time goes on, and at 1 year follow-up, there was no significant difference between the kyphosis correction, whether you insert just one screw or you insert two screws at the pedicle, at the fractured pedicle. So, and also there is a significant loss of kyphosis correction over time. But apart from that, we only had two failures. Both of them were screw pull out at the upper level. Apart from that, up to date, they have been doing very, very well. So that is another, you could say, an innovation. It's not actually an innovation because it has been practiced for a long time, but we opted, so I changed my the practice a bit and try to be cost effective depending on the circumstances. And most of the patients we operated of AO type 3 category or either AO type 4. The study I conducted, I excluded AO type C like this. So these fracture dislocations, you need to go for the long segment fixation. So this is a thoracolumbar fracture dislocation, as you can see. So here we have done the ideal the preoperative workup with the MRIs, especially when the patient is having urology. It's always better to go for MRI and considering the legal aspect as well. So this is the post-op. You can see the reduction is ideal. So when you have the ideal setup, preoperative workup, you can do an ideal job as well. So we don't have navigators or anything. So we use the freehand technique. Right. So this is just to show you, this is a recently operated case with a thoracolumbar fracture. So you can see when you are under pressure or when you are under challenges, you can become a better surgeon. You can become a skilled surgeon. So for example, this case was started at 1:55 p.m. So this is just the marking before you do, before you drape or before you clean. So just to mark the level, so it was at 1:43 p.m. and we finished at 2:24. So you can see all the 5 screws were inserted by 2:24. Yeah, you can see it's a single level pedicle screw at the fractured level and inserted the rods, so at 2:30. So this is my medical officer closing the skin. The time is 2:45. So the case was finished by 2:50. So it's less than 1 hour. So you take less than 1 hour for these cases. So we have come to that level because we have performed that much cases, and so it's being a quite challenge with time for us as well, because we are performing under very tight conditions. So this is the post-op X-ray and the CT of that patient. So that is another a change in my practice that I had to consider because of the circumstances. So we have performed a considerable amount of C1, C2 fixations as well. So this is a recently done case. So you can see this is a child who had high riding vertebral arteries on both sides. Right. So so another innovation that we have, I have practiced and I have noted the the excellent outcome of that is using the fibula as a graft for corpectomies. So you can see a considerable amount of fibular grafts in 2-level corpectomies. So we don't have this the anterior cages, so it doesn't matter. So fibula has functioned as a very good graft. I can recommend you excellent graft with low morbidity and very good fusion rates. Right, cystonostomy as an adjunct in traumatic brain injury. I have performed 108 cases of cystonostomy over the last 4 years. And what I have noted that cystonostomy gives sometimes amazing results, quick results. And what is important for us as a subset of neurosurgeons with poor resources, it's cost effective in terms of cranioplasty. So there is no need for cranioplasty most of the times, but it needs expertise and dedication, especially a person like me. You are the single neurosurgeon. You have to come at night and perform all these surgeries. So you have to be a dedicated person because it needs expertise. My medical officer cannot perform a cystonostomy at the moment. So it takes some time. It has a learning curve. So these are the limitations. But I have witnessed, so what I have seen, it gives you excellent outcomes. It gives you quick results compared to the decompressive craniotomy that we have been practicing so long. So these are a few examples. Sometimes we don't have these EVDs as well. We just put the NG tube, the feeding tubes there. So we have, you can see the bone flap is being kept. This is done 2 weeks back, a young child. So this is post-operative day 3. And you can see the bone flap is kept floating. No need to fix the bone flap as well. Right, so these 3, the cystonostomies, the short segment fixations, and the evacuation of ICH through the mini craniotomies have been major innovations at my center, which I have been practicing for the last 4 years, and I have obtained good results. And I can guarantee that this is cost effective. All these 3 are cost effective, especially for low resource centers like us. So just to show you a case of cerebral abscess recently evacuated. So now this patient presented with the GCS of 8, but we did not have ICU beds. So I completely excised with the capsule. So we had no choice sending him to the ward back. But he did really well. So try to excise the capsule because we need to send these patients to the peripheral hospital. So you can't take a risk. We can't keep them for IV antibiotics for so long. So we have to send them to the peripheral hospital. So this is the patient. This is post-op day 2. He remarkably improved. So this is the day-to-day practice. This is the normal phenomenon, and this is actually the routine for us. And it's being a day-to-day, daily struggle for us. So we have still achieved, or we have operated in complicated cases like this as well. So this is another example of anteriorly placed, anteriorly located meningioma. You can see it's a big one, expanding over 5 vertebral levels. So you can see the axials, it's anteriorly located. So these type of cases are challenging for you, even for the most experienced and most well-equipped neurosurgeon. But this is the pre-op. So we have operated on these type of tumors as well. So we have approached from posterolaterally and from the left side, and I have fixed on the unilateral fixation done on the right side. So this is the post-op, the MRI. I was able to get an MRI done. Usually it's very difficult to get a post-op MRI done because of the limitations in our setup. So it's only a very small amount of residual. So had taken out around 85 to 90% of the tumor. And this is the axials. That's the small residual there. Right. So just see the size of the patient. See, I'm pretty sure that you can imagine how difficult it was to when you insert the screws in this type of patients. It's I mean, you can't see anything. You virtually see nothing in this through the C-arm. So it was just like freehand without the C-arm, the insertion of the thoracic pedicle screw. So it's these things are difficult under the circumstances. So this is her initial preoperative power was 0, and she's still recovering. So her power is improving slightly. Right. So let me show you the video of that. Let's see if I'm having that one. Yeah, but not sure whether the quality of the video is good or not. Let's see. Yeah, so initially we have done the fixation, and I'm approaching to lateral corridor. Again, sorry for the quality of the video. I think there's some problem with the USB drive there. So with gentle manipulation of the cord, it was a calcified meningioma to make the things worse. Yeah, right. And my scissors are not very sharp, so it was very difficult to incise the tumor, so I had to use the rongers as well. Okay, so let's go into the next slide. Then next patient. So we have done these type of complicated and complex cases as well in our center. So you can see it's a deformity, this kyphotic deformity we have corrected, and she was osteoporotic as well. So we had done the cement augmentation as well. So I mean, it's not easy, but gradually we have our staff and all of the nursing staffs, and everyone is up to the task and been doing really well. So this is a case recently done, another challenging case, an epidermoid cyst in the middle fossa, close to the engulfing the middle cerebral artery branches. It's a young boy, 18 years old boy. So we operated on him. This is 2 weeks back. Mild facial nerve weakness was there. Apart from that, he had temporary weakness on the right side. So this is the post-op CT. Tumor was completely taken out. The bone flap I have not replaced. That is, sometimes I don't replace the bone flap intentionally because I had some bad experiences with post-op bleeding, depending on there are a few issues with the anesthesias as well, the post-op management, because we don't have post-op, a dedicated post-op neurosurgical care and an experienced neurosurgical, a dedicated neuro ICU we don't have, and also we don't have experienced staff sometimes. So you had to think about that aspect as well. So I had few bad experiences which I don't want to talk today. So this is the case. It was done on 23rd. So this is the epidermoid cyst. We have split the sylvian fissure, and I had gone into the tumor there. So as you know, the epidermoid cyst don't need a lot of manipulation. You can take it out with the suckers and the micro dissectors. And you don't need to dissect a lot as well. And once you expose the tumor, you can suction.
Hey.
Hey, John.
Oh, I'm sorry.
Okay. No problem. Right. So you had to, so I had to initially expose the internal carotid artery and the middle cerebral artery, and then trace it towards the tumor, and then expose the tumor and take the tumor out. So I don't like these fixed retractors for a long time. So I regularly remove them, or I ask my assistant to hold it for some time without applying much pressure. So a lot of perforators were there, so you had to preserve all these perforators. So it needs, so sharp dissection always as much as possible. So if you follow the basics, that's all. So what you need apart from that, which cannot be taught, is the patience and gentle handling and the composure. So all the other techniques you can learn by someone else, but what you have to learn by yourself, what you have to experience and understand is the temperament, the composure, what to do at difficult circumstances, troubleshooting, and control your ego at difficult situations where there's a temptation as a neurosurgeon to take all the tumor out, even at the critical structures. So you have to have that the mindset, and you have to suppress your ego and think about the patient's safety. There is no harm in leaving a sliver of tumor adjacent to a critical structure rather than risking the patient's life and trying to be a hero and trying to have a nice post-operative picture. So that is very important, especially when you are working at the peripheries with limited resources. There's a difference between the ordinary neurosurgeon and the neurosurgeon with an intention to take the whole tumor out. So you always try to take the whole tumor out, but which is not at the expense of the patient's safety. So you go with the intention of removing as much as possible. But depending on the circumstances, depending on the situation, you have to control yourself. That is the key. But it's not like just removing a part of the tumor and then coming back. So those are two different attitudes and two different intentions. So that's it. Yeah, so the whole tumor was taken out, and yeah, right. So this is at the end. Okay, so quickly we'll move on to the next case. Yeah, this is you can see this is a case of a 75-year-old male presenting with a recurrent meningioma, a recurrent posterior fossa large meningioma. Actually, this patient was presented initially to the National Hospital, the main center of our country, and the neurosurgeon who saw this patient, he's 75 years old, has suggested, considering the age, the conservative management and the VP shunt, which I think it's actually reasonable after discussing with the patient. Because he's 75, at that time, he did not have much symptoms, and they were reluctant for surgery. They were scared of surgery. So he sent back this patient because he's from my area. So, but unfortunately, what happened, I explained to them, I explained to the relatives, this is the situation, this is the condition. But unfortunately, so I also wanted to insert a VP shunt as well and do a considerable tumor resection, a safe resection, a safe debulking after discussing with the relatives. Actually, the relatives were happy to go ahead with the surgery. And at the same time, the patient deteriorated. He had difficulty in swallowing. He had lots of symptoms related to the tumor, like vertigo and headache, and so he deteriorated over time. So we decided to go and operate on this patient. So as you can see, this is the preoperative MRI. So we did the MRA as well as the venogram, which showed obliteration, the involvement of the sigmoid sinus, and also partially this transverse sinus as well. So I'll show you the preoperative CT, the contrast CT. As you can see, both the supratentorial and infratentorial component is involved. So this is the intraoperative, the images. So you can see this is the extradural or the external component of the meningioma. So and this is what we did. This is the post-operative the CT. So there was a bit of hydrocephalus, and we had to insert an EVD post-operatively. So a significant amount of the tumor has been removed. So this is the MRI. He's a doctor's relation, so I was able to get a post-op MRI done within the first 72 hours. So this is the post-op MRI. I'll show you. I was not trying to remove the whole tumor. So we have done quite a reasonable job. So we have removed around 80–85% of the tumor without it causing a deficit to the patient, most importantly. He's still recovering. We had to do a tracheostomy in this patient because he had preoperative difficulty in swallowing as well. So he's still in the ward. So this is the post-op MRI. The sigmoid sinus was obliterated, was involved. You can see the post-op. I done a considerably good job. So let's see. few intraoperative the videos of that tumor. Yeah. So the external component was initially removed, and then the dura was opened to get rid of the infratentorial component. Tough tumor, tough tumor, firm. So always try to stick to the principles. So for us, as most of the neurosurgeons working under these circumstances know that most of the times we are left with the scissors, the micro scissors and the bipolar. Sometimes we don't have even the CUSA, and we don't have soft tissue debriders. So when you encounter these firm tumors and firm to hard tumors, it's a bit difficult. So you can see. So it's involving the sinuses and the other surrounding structures. So it took around 4 hours. So fortunately, I had the CUSA, but the CUSA was not very much useful at this juncture. So I had to use these branches, which I don't regularly use operating with on-brain tumors. All right. Okay, so try to preserve all the nerves, or didn't have any facial nerve palsy post-operatively. So considering the time, so I'm just skipping this. So this is at the end. Right. Right, another case. So another difficult case. This is a patient presented with a pathological fracture. You can see a thoracic T7 pathological fractures. So you can see he presented with a 0 power of bilateral lower limb. So we did a posterior corpectomy, posterolateral corpectomy, and inserted the cage as well. So this is the post-operative. He could move his legs when the gravity eliminated. So considerable improvement considering the preoperative status of the patient. So you can, with difficulty, move the left leg against gravity. So we have done several cases posteriorly. This is a case of lumbar corpectomy done posteriorly with the posterolateral approach in a patient with breast CA with a metastasis to the L1 vertebrae. Right, okay. This is another case, a cranial case. Now, this is a patient presented with a very thick subarachnoid hemorrhage and with the GCS of 6. So what we have seen in these patients, this type of patients with thick subarachnoid hemorrhage is coming with low GCS. They had very poor prognosis, and most of them, they died at the medical wards even before performing getting an CT angiogram done. So in this case, so what I did, we did a decompressive craniectomy initially. Unfortunately, I don't have the preoperative CT of this patient. The presenting CT of this patient. This is after decompression. So initially we did a decompressive craniectomy of this the day after the presentation. So he presented with a very thick and subarachnoid hemorrhage causing the mass effect. You can see this is after decompression. And so we let him to improve, and we did the CT angiogram later after a few days. So this is the CT angiogram. I don't know whether you can appreciate an aneurysm here, but this is what we left, what we are left with. And this is the maximum that my radiological colleagues can provide. So, I mean, there is nothing to blame them, but they are doing their maximum. Though this is considering the resources, that's all that they can give us. So it's quite difficult. It's believe me, it's quite difficult. So, right. So this is the postoperative CT. Unfortunately, this patient developed a postoperative pneumonia, and but he recently he went home walking. So I'll show you a video of the intraoperative video of his aneurysm clipping, because in these type of situations you don't have a very clear picture of the aneurysm, so you have to be very, very careful, because you have only a part of your three-dimensional knowledge about the anatomy. So this is the decompression. You can see the decompression is being done. Now the brain is lax, right? So initially you release some CSF at the opticocarotid cisterns, and then do the Sylvian-Fisher splitting. So in anterior communicating artery aneurysms, I don't usually go for a complete split. It's just a partial split is enough. But I always see the internal carotid, visualize the internal carotid artery, and then trace all the way towards the anterior cerebral artery. So you visualize the optic nerve, the optic chiasma there, and you release the adhesions. Always sharp dissection. Now you visualize the aneurysm. You have to visualize both the anterior cerebrals and both the A2 branches there. So I did not expect this to be bilobed, but it was a large aneurysm. So when you are working under these type of circumstances, under these resources, so the surprises are very much higher that you had to anticipate. So your adrenaline levels goes up in these type of situations compared to a neurosurgeon with fully equipped resources. So you can see the perforators and the dome of the aneurysm. These type of situations, I don't take a risk. So remove a part of a little bit of orbital gyri. You can see the A2 here. The A2 on the other side as well. I'll go through this quickly. You can see one lobe here, the other lobe there. The other lobe is attached, adhered to the optic nerve on the contralateral side. now once the visualization is clear, so we have a severe lack of aneurysm clips as well. So we don't have the correct ideal length of these aneurysms, and we don't have straight aneurysms. We have only curved aneurysms. So again, it's a bit of problem. So we are trying to get these consumables restored as much as possible, but sometimes it's not very easy. So you have to go, I mean, you have to proceed with whatever the resources you have got. So I had visualized the dome completely and making sure there is no blood vessel in between. Right. So the one is right there, and the other one to the other lobe of the aneurysm. Then, so you have to see whether you have done the correct thing there. So you can see the dome there. So visualize it completely. And now you are sure that you have done a correct job. Okay. So this is the post-op CT. He had a bit of trouble with pneumonia otherwise, so he had no weakness and his GCS was 15. This is an unfortunate case which I want to show you. This is a case of a 31-year-old lady, immediate postpartum lady, who presented to me with this tumor in the around 20th week of her pregnancy, at the second trimester of her pregnancy. So I advised her to get the tumor removed once the baby is delivered, but she presented to us late. So you can see it's a large tumor. It's a large epidermoid cyst. Both compartments, both infratentorial and the supratentorial compartments. So this patient presented with severe symptoms and weakness on her body because of the pressure effect on the brain stem. So I operated on this case, and I can show you the pictures as well, the intraoperative pictures very quickly, without taking much time. It took around 5 hours for me to take this tumor out. So the posterior fossa craniectomy is done. I wanted to operate this in stages. So initially the infratentorial compartment, and later the middle fossa, through the middle fossa compartment, because I know my limitations, I know my resources. So CSF is released at the foramen magnum, and now you see the tumor there, large tumor, and visualize the cranial nerves, the lower cranial nerves. And it was tightly adherent to all the nerves, all the cranial nerves. The 7th, the 8th, the 5th, everything. But all the nerves were preserved very carefully. So working in Windows and had to be very patient in this case. You can see tumor everywhere. You see the brain stem there? And post-operatively, she did very, very well. But unfortunately, again, she developed pneumonia, and we had to put her on a tracheostomy prophylactically, because I'm quite sure that we preserved all the lower cranial nerves. So we did this swallowing test. She could swallow, but prophylactically, for a better pulmonary toilet, we did the tracheostomy as well. And she didn't have any weakness, and she did not have a facial nerve palsy only for a few days. But very unfortunately, she developed fever, and her fever spikes were very, very high, like 105, 104 all the time. And she was on antibiotics. We had a problem in last few months that our antibiotics were not very efficient. And even though we were administering antibiotics, the patient's fever, most of the patients' fever were persisting regarding, raising a question regarding the efficacy of the antibiotics. So we had to put her on high-five antibiotics, and we did the post-op CT showed hydrocephalus as well, impending, moderate hydrocephalus. So we did an EVD as well. And at that time, we obtained a CSF sample and sent for culture. And then it came as Acinetobacter positive. So to my surprise, because Acinetobacter is not a common organism that you get in these type of situations. So the possibility was we had inserted an EVP shunt before, so it could be the culprit causing would have caused the infection. And because of the infection, because of the ventriculitis and the adhesion, she might have got the hydrocephalus despite the obstructive hydrocephalus despite the VP shunt. So then it was sensitive to meropenem. So she was on meropenem for some time under the guidance of the microbiology team. And unfortunately, she developed pseudomembranous colitis. And she developed ascites as well due to the accumulation of peritoneal fluid. But still, and then we stopped the meropenem, stopped the antibiotics, we stopped the culprit antibiotics, and we started her on the treatment. And then we did we referred her to the GI surgeon as well. And then he did colonoscopy, and it was confirmed as pseudomembranous colitis clinically. And unfortunately, she developed sepsis, and her platelets going down, and she was losing protein. And because of the high output, we had to insert an abdominal drain, and the abdominal drain was like very high, around 2 to 3 liters per day, sometimes, to our surprise. And she was losing lots of fluid, and still her fever was persistent. And despite the antibiotics, she had a very high fever. And then what we did, we did the CT scans. We did the regular CTs, the imaging. And so this is the immediate post-op CT. So there was no problem with that CT. You can see the VP shunt in situ on the right side. That was done by one of my medical officers as an emergency procedure. And this is, you can see it's 19th of July, and this is 1st of August. There was a suspicion of an abscess. in this region. And we did the contrast CT as well. And the radiologist was not very sure whether there was an abscess, and he thought there was no abscess. But I thought clinically there could be an abscess in this patient, and so I wanted to reopen and see what's going on. Let me check a little first approach here. So this is the so I thought going through the posterior corridor would be not very safe, and the abscess was actually in the supratentorial compartment. So I made a small opening in the middle fossa, the temporal region, and wanted to see what's happening. So let's see. Now you can see slowly. Let's see what is happening. You can see pus coming out. So this is, you can see the evidence of an abscess. So what I thought was correct. We were planning an MRI that day, but she deteriorated further, so we had to take him to the operating room. So around 20-25 cc of pus was evacuated, and it was deep-seated pus. Deep-seated pus, and you can see the residual tumor. So I removed the residual tumor at the same time. I know she is a compromised patient at that time, but I want to do it very quickly, and we did it reasonably quickly. And we removed the whole tumor, the whole residual tumor, taken out. So I'll just skip this, considering the time factor. And yeah, completely tumor was taken out in around 1 hour and 10 minutes. But see what happened later. So this is the immediate post-op CT. You can see what has happened here. So it's a infarct or thrombosis of vein of Labbe. So what would have been the reason behind that? Because she was losing fluid, she was dehydrated, and that would have triggered the thrombosis of this, even though we did not damage the vein, but we were close by. You could have seen that in operative videos. So that would have triggered the thrombosis of that vein of Labbe, which is not very common, but unfortunately, that happened. And also patient developed sepsis, and she continued with sepsis with low platelets, and she was losing fluids. And now GCS, the conscious level is low, she's not improving, and her prognosis looks really bad. Now you can see it's almost after 3 days, it's a full-blown infarct there. And another infarct in the region of the thalamus as well. So these things can happen. So the things can go wrong. So at any time. So I had explained, I have been very honest to the patient and the relatives. I explained the condition to her husband and to the relatives. They wanted to get another opinion from another neurosurgeon. I said, it's perfectly all right. You can get all the details and go and get the opinion. So that's the thing. I mean, when things go wrong, you have to be very, honest to the patient. You have to disclose what has happened clearly, because there is nothing wrong in what you perform. There may be nothing wrong in what you perform, your intention, but things can go wrong depending on the circumstances. So this patient had a horrendous post-operative course, and it's really hurting. So you operate around 5-6 hours, and you develop a condition like pseudomembranous colitis in a patient like this is really frustrating, and it really hurts you as a neurosurgeon. So I'm sure people who have had similar experiences, they understand what I'm telling you. Right. So yeah. These are a few cases that we have done last month, right? So it's a posterior fossa meningioma, it's taken out. And another case, this is a young lady presenting with this ICH with rapidly deteriorating GCS. So I had to operate even without a CT angio. It was an AVM. The AVM was taken out. So this is immediate post-op. There was a little bit of bleeding, but the post-op CT angiogram was done. So there was no residual AVM. And this is the, sorry about it. So this is the presenting the CT and the immediate post-op. This is the CT angiogram done after a few months. It did not show any residual. And this is she came recently for cranioplasty. That's why I wanted to show you. These cases were done without a CT angiogram. So in our setup, we had to operate in that type, in that manner as well to save the patient's life. So she has had any deficit, like she was doing really well. A similar case, presenting to us from a peripheral hospital with a GCS of 3. So with impending coning of this patient. So you can see the diagnosis here. You know what it is. So it was a Sunday and I was not there. So I was in Colombo. So I asked my medical officer to do a decompression, and I started my journey while he was doing a decompression. And this is the post-op. So you can see he just sent me a photo through I was driving. So he said he's a meningioma. Yeah. So then I removed the meningioma. It was a hemangiopericytoma, and it was a large one. So no contrast CT, no MRI. So we had to operate, and this is the patient. So he had no deficit, and he was discharged after 10 days post-operatively. So this is my ward. You can see these few beds are my whole ward. Right. Okay. I have the video, but I don't have much time. So this case, I did this case with Nargisa that day in May. So this is again a patient presented with low GCS, a patient with meningioma. So I asked my medical officer to do a decompression first, and then we removed the tumor. So we have operated in various ways under various circumstances, but we have shown that I mean, if you attend your cases as early as possible and with the correct technique, I mean, if you have the confidence, you might be lucky as well. Last slide for the day. A doctor's mother working in my hospital, CP angle tumor, presenting with a CP angle tumor, and I operated. We preserved the nerves, we preserved the 7th nerve, all the nerves, and this is what I saw the next day morning. The worst thing that you could ever imagine in a patient with CP angle tumor. So a large hematoma. I can show you the the intraoperative, the video within a very quickly. So just to show you that we did everything well. But unfortunately, it was not I mean, not that firm. The consistency was favorable for the CUSA. And to be honest, in my in our setup, it's difficult to preserve the facial nerves if the tumor is firm and large. because we don't have neuromonitoring, and it's a bit difficult sometimes. But I have managed to preserve facial nerves in several locations when the tumor is soft. So most of the time, our patients develop facial nerve palsy, especially in cystic epidermal, cystic CPAs, and very firm tumors and large tumors, more than 4 centimeters, 3 to 4. So I always explain them, tell them that so we all do have restrictions in our setups, so everything is not possible. So I always try to be honest with the patient with the complications and the other expected sequelae. So I mean, this was done to my understanding very well, and with preservation of all the blood vessels and all the nerves. And what we do, we know our circumstances, we know our restrictions and our capacity. So what we usually do, we ask the anesthetist to give a Valsalva maneuver, and we ask them to increase the blood pressure to around 150, and we achieve hemostasis over 15 minutes. Right? We had to be. I usually try to be very, very precautious and very, very precise with hemostasis, because I have had bad experiences in the last few years. So there is no point in blaming your anesthetist whenever you get an ICH. There is no point in blaming the medical officers in the ICUs looking after the patients post-operatively. You have to be very, very careful and cautious about what you do, because the patient dies from post-op hematoma, and the relations will come and tell you the patient died from infection. They think the patient died because you operated on this patient. So operated and patient died. It doesn't matter whether it is post-op pneumonia, post-op pseudomembranous colitis, or hematoma, or whatever. So especially with the patients with the type of people in countries like ours, so it's very difficult. So I'm sure these things are not great problems or great issues, and most of the neurosurgeons from some countries, they will not understand what we are talking about. But the neurosurgeons who work under these circumstances, they know how difficult it is to convince the patients, convince people, and to tackle with them. It's really, really difficult, especially when things go wrong, because as a neurosurgeon, you will be very, very you will be in a very critical or a difficult situation in this type of event. These things happen. So actually, this was a miscommunication between the staff there. So the patient's pupils changed, but it was not properly communicated, and they couldn't control this patient's blood pressure. So unfortunately, I evacuated, but when this type of things happens, you have lost your battle. I evacuated the hematoma, but the patient is in persistent vegetative state. So we did the tracheostomy and the feeding tube, and we sent the patient home for rehabilitation, GCS of 3. Right. So finally, so this is the take-home message. So healthcare is performed by conscientious but fallible people. Errors inevitably occur. So we need to incorporate system thinking, in which is responsible for the patient's safety, which includes including all parts of the healthcare team and the infrastructure, from hospital administrators to bedside nurses. Everybody is responsible, not only the surgeon. Even though when something happens, it's all yours. It goes all under your account, and most of the time, most people try to palm off. Putting the blame on the neurosurgeon, but it's not the issue. It's not the case most of the time. So the effective communication with the team members is essential. Right. And there are many avenues to pursue in improving patient safety. So you need to learn from your mistakes. So for that, you need to have your database and a checklist. The benchmarking is very important. And we need to maximize the safety of the patients with all these the strategies. And this is what we have achieved so far. So as I mentioned you earlier, I am working at the least, the most resource poor center with the least facilities in the entire country, recently established. What we have operated on 894 major cases over the last 3 years. And these are the numbers. We have done 19 trauma cases, 176 trauma cases, 99 tumors, instrumentation. This is, remember, this is without a single lateral mass screw or a pedicle screw or whatever the cages from the hospital. So it's all of these are private construct, but the patients kept faith on us. And 275 ICH evacuations altogether, 41 aneurysm clippings and 44 spinal tumors and few more, which I have not included here. So I think we have done reasonably well, and we have done quite a good service to the population, the people in this province. Sometimes I can remember there was a plan to close the center, considering the circumstances, but I think we have given the correct answer, because these poor people are the ones who are getting benefited by this, right? So we have toiled very, very hard, and our lives have been miserable sometimes, considering the circumstances. But ultimately, I think you can be happy considering these circumstances. So the take-home message is you have to be very, very, you have to always think about the patient safety. That's the priority. And when things go wrong, it can go horribly wrong. So you have to be always be able to justify what you do, and you had to always to be on the safe side. And improving quality of care is very important. So outcomes must be measured before they can be improved. That's a very important aspect. So it involves the understanding the current level of performance, what you are doing. So that's why you need to check what you are doing. You have to identify the areas that you need potential improvements. You have to identify your mistakes, your deficiencies, otherwise you can't correct them. So it is actually a multidisciplinary approach. So from the, as I mentioned, from the administrators to the nurses and everyone, even the healthcare assistants, they have a role to play. So it's a team. It's a team if just not just one person's game. So that's why, however much you perform a superb surgery with a superb technique as a skilled surgeon, patient get an infection, the patient dies. So the whole thing you did is useless, is a waste. So that's the thing. So so improving the quality and improving patient safety is of utmost importance. We, most of the time, we innovate, we try to innovate. Sometimes we don't think about sometimes all these aspects. We think about the patient. Sometimes we don't think about legal aspects. Fortunately, in my country, the legal, the implications are not that high at the moment, but in the future, there is high chance that it can increase, and the patient will act in as the other countries where there is strict laws. So as I said, lifelong learning is important. So data collection, analysis, and application, the knowledge to the healthcare system is very, very important. So sometimes there is this concept with volume outcomes in neurosurgery. In high volume centers, there are subspecializations, but unfortunately in my country, we don't have the type of subspecialization, and we don't have that type of high volume centers. So it's not possible all the time. So neurosurgeons, we have an obligation to expand our clinical priorities, patient safety, cost efficiency. So as a high-risk field, we can make the most impact and significant gains in improving the patient safety, quality initiatives, and cost effectiveness. So this is the take-home message I need to convey you. So that is all what I have to show you for the day. So I think I have given you some kind of a message to the rest of the world with my experience. And I think you can take something out of that and which will be important for you in your rest of your career. Thank you very much. Thank you, John.
Okay, excellent, Sarat. Your dedication is obvious, taking so much time with your patients, getting all the data together. That's a lot of work, and we appreciate it. And now, Giza, I'm sure you probably have a few words to say. Do you have any comments?
Yes, I first of all want to say thank you very much for the biggest information I could ever got for the last few months, maybe, because within 1 hour or maybe 1.5 hours, I have seen so many cases which you presented. And of course, I took notes about, again, how to manage, how to approach, especially intercerebral hemorrhage, because we usually go from middle frontal gyrus, and we know that it's safe place. But today you showed nice approaches from temporal gyrus. And of course, I know that a lot of surgeons sometimes don't take approach. Maybe they don't feel safe or something, but you showed that there can be good outcomes from that as well. About sternostomy, of course, thank you so much for presenting the case about sternostomy, because yes, it works. And being with Ipcherian, I can tell about that loudly every time. And thank you very much for all oncology cases which you presented today. Yes, we cannot be safe from mistakes or outcomes or complications, but we have to be ready for that. And for me, for young neurosurgeon, it's very important to listen to that notes which you are pointed in today. Thank you so much.
Thank you very much, Nargisa, for your comments.
Yeah,
and we are waiting for a grand round from you as well, isn't it, John?
Yes, we've had a few grand rounds from Russia.
Yes, I just wanted to tell that yesterday and today I found at least 5, one of the best neurosurgeons from Russia. So I got Gmail addresses and numbers, and I'm going to contact you, John, sir, after some time regarding that.
Yeah. Any ideas you have in improving education in neurosurgery, we're welcome. You know, like the gentleman you just saw you approached. Excellent. We just basically say the neurosurgical TV would like to televise your talk on whatever. So we'll be able to give them a platform, and it'll also help you to network. That's how you meet him. For example, when you met Sarat, but you meet other neurosurgeons like the gentleman you're talking about, if you arrange that webcast, you'll get to know him. You get to know his little community maybe that comes to his webcast. So it's good for you.
Yes.
As far as networking, of course, the knowledge, but the networking is also very valuable. So, okay, anybody else have a comment? Dr. Sirhale, do you want to comment on anything? You don't have to. Okay, very good, Sarat. We appreciate it, and we're going to see you in approximately 2 weeks. We look forward to that.
Okay, thank you very much, John, for the opportunity, and you're doing a great job. I can tell you anytime. So you have been very, very helpful for all the neurosurgical community so far. Thank you.
Thank you. Okay, we'll go off the air now and